Hello, everyone, and welcome to the sixth edition of the Annual Thyroid Update 2020. And right at the onset, I'd like to thank Dr. Matthew John and his team for this kind invitation, as well as congratulate them for having been able to conduct this meeting for the sixth consecutive year, and especially this year because of the difficult times that we all have seen in the last 2 to 3 months. And still, we've been able to conduct this meeting on a virtual platform. So over the next 20 minutes or so, I will take you through this topic of free versus total thyroid hormones. And to give it a bit of clinical flavor, I would present to you a couple of cases that I have seen in clinical practice and base my discussion around those cases. So to begin with the presentation, I think we all know that thyroid hormone assays have been into the market for a very, very long time. And if you talk of the earlier developmental assays, way back in 1950, the first assay was essentially just to consolidate the amount of iodine that is available in the blood, a process known as protein-bound iodine that precipitates iodine. And we know that 90% of the iodine is because of T4, so a very indirect measure of the thyroid hormone in the blood. It took another 2 decades for first-time radioimmunoassays to actually come up in the market. A couple of Nobel Prizes were also won because of this invention, which did change the paradigm not only for thyroid, but a lot of other hormonal assays. Another 2 decades for the immunoassays to come into the market, which is indeed something that we use a lot, especially in the Indian market. They're rampantly available, they're cheap, and quite sensitive and specific. And another 10 decade, in somewhere in 2000s, we had the gold standard, the so-called LCMS, the liquid chromatography and the mass tandem spectroscopy, which led on to the most efficient and the most sensitive and specific assays that we have. But obviously, it has its own limitations of cost and the procedure, which is very tedious. But over the years, over the decades, I would say that definitely we have improved our sensitivity and our specificity, our reproducibility of the thyroid test. That has definitely improved. What we also know from the past and over so many years, that thyroid hormones are essentially very, very well regulated with respect to the hypothalamic pituitary axis. We know that the T4 and the T3, the hormones that are released by the thyroid gland, are essentially regulated by the pituitary and the hypothalamus by TRH and TSH. And there is a feedback inhibition from T4 and T3 back to reduce their production when in excess. In patients who have primary hypothyroidism, we know that the problem lies within the thyroid, wherein the thyroid is not doing its job of adequately producing a lot of hormones, and therefore it does have a feedback increase of TSH and TRH from the pituitary and the hypothalamus. On the other end of the extreme, we have people with primary hyperthyroidism, primarily seen in people with Graves' disease, wherein the thyroid gland is actually overfunctioning. And this in turn leads on to suppression of the TSH and the TRH that is produced. So therefore, this is what is the normal physiology that I'm sure all of us are aware of. Amongst these so many hormones that we can use to assess the thyroid function, I think what one stands out is the TSH. And why I say that is because TSH indeed is easily available, and it is also a hormone which has a negative log linear relationship with T4. And what this complicated word actually means is that for very small changes of T4, there could be logarithmic amplifications in TSH. So it could detect the problem, which may be small, in a much easier fashion. And therefore, TSH is definitely one of the first tests that we would always order in any patient who we suspect to have thyroid dysfunction. Another reason being that there are very good assays available. There are third-generation assays available for TSH, which can detect TSH as low as 0.01. And also because in most of the people, if I just do a TSH, I would be able to assess their thyroid function adequately, provided they don't have any hypothalamic pituitary disease, or in normal homeostatic situations, just TSH is enough. But today's talk is not on TSH, it is on T4 and free T4 T3 and free T3, so total versus free hormones. So what we also know from our knowledge in physiology that there are two types of hormones. There are the free hormones and the bound hormones. The free hormones are the actual hormones which actually get into the cell, work on the nuclear receptors, and thereby bring up about their action. Whereas the total hormones or the bound hormones are essentially the hormones which are bound to different proteins, maybe proteins like TBG, transthyretin, and albumin. And these are the bound hormones. And when we say the total hormones, it is the bound plus the free hormones that we talk about together. Similarly for T3, however, T3 is more strongly bound to albumin. But before we embark on ordering a test or deciding whether we have to order a total hormone or a free hormone, I think the most important thing that we have to know is that how good is our lab and what kind of assay our lab is using to determine these hormones, because it depends a lot on the sensitivity, the specificity, and the kind of assay that is used, the kind of method that is used to assess these hormones. And most laboratories would measure total T4 and T3 by using a competitive chemiluminescent assay. And I think for all the postgraduates who are listening here, it is important for you to understand what is this competitive chemiluminescent assay, how is it different from radioimmunoassay, what are the other kind of assays available. And so maybe I'll spend one or two slides on this competitive assay. So basically, when you talk of any immunologic assay, there are two types. There is a competitive assay and there is a non-competitive, which is also known as the sandwich assay. In terms of total T4 and free T4, we're talking of the competitive assay. When you talk of TSH, we talk of the non-competitive assay. So I'll tell you more about this competitive assay, and then going through the theory, I'll probably show you in this picture. So whenever we talk of this competitive assay, there has to be a competition, and there are three components here. There are two types of antigen. One of our antigens is our hormone, the hormone that we need to detect, like T4 or free T4. The other is the labeled antigen. This is the antigen which we can detect either by radioluminescence or by chemiluminescence or by fluorometer or by calorimetry, some way in which we can detect the labeled antigen, and the antibody. The third part is the antibody, which is indeed put onto the plates, and this is the third component. So these are the three components that actually participate in the competition. So when there are two types of antigen, they will compete with each other to bind to these antibodies, and during the stage of washing, whatever is unbound is removed. Now, as you see in this picture, that the amount of labeled antigen that we are able to detect is going to be inversely proportional to the actual amount of hormone that was present in the sample, because there is a competition, and if there's more radiolabeled antigen, that means there were more free spaces for it to bind. And that's why the graph for competitive assays is an inverse graph. So as the the percentage of our detection comes down, means that there is more of the hormone that is present. So we're clear with what is automated. This is called automated because we just put the sample in the machine and it does all this for us. There is competitive binding involved. So what is this chemiluminometric assay? So it is essentially nothing but this labeled antigen that we're talking about, and whatever kind of labeled antigen we have would be either a radio-labeled or a non-radio-labeled kind of assay. If we use a chemical reaction there, then it is called chemiluminescent assay. If there is a fluorometer or if there's a calorimeter, then accordingly it is given its name. When we talk of free hormones, they can be detected directly, but then there are indirect methods as well. And in the indirect methods, there's a complex process of calculating the T3 uptake by using, again, a radio-labeled T3 resin, a complicated process, putting it into the formula, and then getting what we get as the free T4 index or the free T3 index. So whenever we look at our free T4 reports, we need to know whether it was a direct measure or an indirect measure. An indirect measure, many physicians wouldn't really get on to the formulas and be able to understand. But if it is direct also is easy to understand, but then it doesn't really cover all the binding capacities of the T4. So that is also not perfect, but maybe better than the indirect method. So coming on to the cases that we'll discuss today, and our first patient is a 34-year-old lady who presented to us with secondary infertility with a previous diagnosis of polycystic ovarian syndrome with 6 weeks of amenorrhea. Now has the following thyroid report that she's come to you with. She's got a T4 which is mildly elevated. The upper limit of normal in our lab is 12.5 microgram per deciliter. She's got 14.7. So when you look at this history more carefully, we read in between lines, we understand that this patient has been having PCOS. So we ask her whether she's been on any estrogen-containing pills. And the answer many often would be yes. And then also now that she has 6 weeks of amenorrhea in a PCOS patient who's trying to get into pregnancy, I think it's important to rule out pregnancy. And we did both, and this patient was actually on estrogen pills for the last 6 months, which she had stopped now, and now she has confirmed her pregnancy. It's important for us to remember, and I think this is one of the most important tables that I will show you in this presentation, wherein we need to decide these are the factors which alter the thyroxine binding globulin, and therefore the total hormones will be elevated if there is increase in TBG binding, and if there's a decrease in TBG binding, then there would be a decrease in the total T4. And these are the conditions where we would prefer to do a free T4 or a free T3 for that matter. So in this patient, we know that pregnancy and oral contraceptive pills both are hormones that increase the thyroid binding globulin, and therefore these are the two reasons why the total T4 is elevated. How does pregnancy affect the T4? It's not only by this mechanism that I just told, that there is more estrogen and therefore it goes to the liver and gets more TBG produced and therefore there is more T4, but there are more mechanisms to it. This estrogen, or during pregnancy, we know in the initial part, there is a very rapid increase of HCG hormone. And this HCG in turn is very, very similar to the TSH molecule, and therefore it works on the TSH receptor mechanism that is known as the specificity spillover effect. When there's a lot of HCG, it behaves on the TSH receptor as if it's TSH, and therefore it produces more T4. Not only this T4 would go back to the hypothalamic pituitary axis and therefore reduce the TSH. And also, because of their increased GFR during pregnancy, there's a lot of iodine loss, and that also increases the demand of thyroxine in pregnancy. So it's a complex process in pregnancy. Again, total T4, if you interpret, you need to know that it can be much more than normal, maybe 1.5 times the upper limit of normal that is expected. So in this patient that we saw, given the confirmed urine pregnancy test, past history of estrogen-containing pills, we know that this total T4 is elevated because of these reasons, and in pregnancy, a T4 up to 18 would be quite acceptable. Coming to our second patient, and this is on the opposite side of the spectrum. This is the story of a 38-year-old gentleman who presented to us for clearance prior to renal biopsy, clearance prior to this procedure. And this patient had an abnormal T4 level, and this patient had a low T4 level. Normal TSH, normal free T4, and a low T4. So this patient requires clearance. The moment we see that there is nephrotic syndrome, we know this is a condition wherein there is decreased TBG, and therefore we don't get worried about looking at this total T4, and we would be able to give clearance because the free T4 in this gentleman was normal. So overall, the point that I'm coming to, when you have to decide whether you have to ask for a total T4 or a free T4, or what you need to know is that you need to understand the comorbidities of the patient very correctly. You need to know which are the comorbidities which increase the TBG binding, which are the ones which decrease the TBG binding, and therefore we need to interpret these values. Not only the comorbidities, it's also very, very important to go through the drug history, because as we see in this table, there are drugs which increase TBG, drugs which decrease TBG, not only increase and decrease TBG, but also drugs which affect the binding, drugs which affect clearance. So any of these drugs for that matter, I would prefer interpreting a free T4, or I would interpret a T4 with a different kind of a cutoff, as we saw in pregnancy. Beyond TBG, we know that there are other molecules that thyroid hormones bind to. So it's not only TBG, even though it's one of the main ones, like 70 to 75% of the thyroid hormone in the blood is bound to TBG, but there's also transthyretin, there's also albumin. And let's look at this case. This is the story of a 35-year-old unmarried lady who went for a master health checkup to a hospital. No history of oral contraceptive intake. She's clinically perfectly fine. She's got no thyroid complaints, no goiter, but she has an abnormal thyroid report and her T4 is massively elevated. Now, in such a patient, we are not expecting any estrogen exposure. She's unmarried, there's no OCP intake. And then this is a genetic diagnosis that was ultimately made for her. She's got hyperthyroxanemia because of a familial dysarthropenic hyperthyroidism. It's a rare disease, but then it's known. There are genetic markers, there are genetic variants. So the point here to remember is that it's not only TBG related stuff, there is also beyond TBG. Rarely these kind of diseases can also have elevated levels. Coming to our fourth patient, and this is a story of a 57-year-old gentleman who's not known to have any thyroid dysfunction before, but gives history of having pituitary surgery 2 years ago and now has a recurrence. Came for evaluation of thyroid dysfunction. Again, no symptoms of hypothyroidism, but when we look at his thyroid reports, both T4 and free T4 are low, but TSH is normal. Now, this is a situation where we think of secondary hypothyroidism. I've already told you about primary hypothyroidism and primary hypothyroidism, wherein the problem lies within the thyroid gland. But if there is no problem in the thyroid gland, but the problem is higher up, that is either in the pituitary or the hypothalamus, wherein if there is a tumor there, what will happen is the TSH will be low, the T4 will be low, and the free T4 will be low. But the very, very important point that we need to remember in our clinical practice here is that the T4 and free T4, even if low, the TSH can still be within the normal range. It's not actually normal, it is inappropriately low. In a patient with primary thyroid disease, if I have a T4 of 3.2, that means that the T4 is low, I expect the TSH to be much, much higher than 1.5. I had expected to be somewhere around 50 or 60. But this person has a TSH which is just 1.45, maybe within the normal range, but we interpret it as a fact that it is inappropriately low. This is the MRI of the patient, and you can see a large pituitary tumor right in the center of the cella. So when you talk of thyroid hormone assays, free versus total in terms of pituitary disorders, many times they go hand in hand. A lot of physicians do prefer using free T4 in their practice, but then overall, this was a paper which was published in Clinical Endocrinology, when they had a large database of pituitary patients. What they found was that the lower limit of free T4 is sometimes not very accurate, and therefore our target of treatment in patients, if you're using free T4 in pituitary patients, should be somewhere in the middle normal range or the high normal range. We spoke of central hypothyroidism. It's rare. It's not that you have to suspect it in many cases, but yes, when you have a history of pituitary surgery, history of radiation, or history suggestive of other pituitary hormone axis involvement, that's when we should consider it. And if you do only a TSH in them, you would miss a diagnosis. This is a story of a 14-year-old boy, again, somebody with weight loss and decreased vision. So that's probably, again, hyperthyroidism, but decreased vision, probably because of a rare tumor in the pituitary. This is a TSH tumor, a TSH secreting tumor. We know that whenever we look at a high T4 or a high free T4, we know the TSH should be suppressed, and in this case, it is elevated. This patient has a large cellular tumor with some apoplexy. TSH tumors are again rare, but then these are patients who again have a discordance between the T4 and TSH. The T4 is high, but the TSH is not suppressed. So in any patient, when we do evaluate with symptoms of thyroid toxicosis, we expect a TSH to be low. And when it is low, we check for a T4 or a T3. We check T3 mainly when the T4 is normal, because that's when we suspect T3 toxicosis. But if the TSH comes back high, there are two possibilities. Both of them are rare. One is there is a TSH secreting tumor, and second, there is resistance to thyroid hormone. I'm not dwell into them because they're rare, but move on to the next case. So for pituitary cases, when you have to decide between T4 and free T4, and if you use free T4 as is used commonly for monitoring people with pituitary disease, we must remember that our therapeutic thresholds should be for mid-normal or high normal free T4 values and not low normal free T4 values. Talking about this sixth patient, and this is a story of a 36-year-old obese lady who presents to the emergency with febrile illness. She's diagnosed to have urosepsis secondary to a pyelonephritis. She's on inotropes, and our enthusiastic intern sends a thyroid function as a cause for obesity. Guess what we get here is something which is expected. We never check thyroid functions in somebody who's sick, somebody who's in the emergency because of this entity called acute thyroid syndrome or non-thyroid illness. Here we have a T4 of 3.6, which is low, but the TSH is normal, free T4 is normal, and there are a whole lot of diseases, a lot of mechanisms described as to why people in critical illness can have abnormal thyroid functions. It essentially boils down to the simple fact that the body is trying to conserve energy, it is trying to reduce the metabolism or the metabolic rate of the body and convert all this active thyroid hormone to RT3, which is an inactive form. Now, when we look at the changes within the acute thyroid state, we see that all the hormones change, the RT3 goes up. But when you talk of the free hormones or the total hormones, we see that the T4 starts decreasing much earlier and comes back to normal much later, but whereas free T4 is less affected. So again, this is one situation where we would like to measure free hormone rather than the total hormone. In talk of treatment of acute thyroid syndrome, most guidelines do not recommend. There is a lot of controversy here, but on an average, treatment may not be recommended in people with non-thyroid illness syndrome. So ultimately, I've covered a lot of diseases or disease states where we have to decide between a T4 or a free hormone, a total hormone versus a free hormone. But then our ultimately aim is to provide accurate treatment to our patients. I did cover a lot of disease cohorts, but then what in people who have no disease? This was one interesting study that I came across wherein they looked at evaluation of different types of thyroid hormones and their correlation with TSH. And what they found was that it is the free T4 which should be actually assessed in healthy individuals because it correlates better, and the total T4 excuse me, may be more meaningful in people with hyper and hypothyroidism. So it is free T4 for healthy individuals and total T4 for people who have disease states like hyper and hypothyroidism. So with this, I come to an end of my talk. And just to conclude, I would say that the first and the most important thing that you have to remember before you embark on ordering or choosing between a total or free hormone is to know your lab, know the assay that they are doing, and then order. It's important for you to assess all the comorbidities because there are comorbidities which may increase the thyroid binding globulin. There are comorbidities which may reduce the TBG, and that has to be taken into consideration. Not only the comorbidities, but even the drugs. The drugs are also important, and that may also change your decision. Certain states like pregnancy, again, free hormones may be preferred because of the multiple factors that change the total hormones. And acute thyroid syndrome, another place where free hormones are preferred as compared to total hormones. So all said and done, and this is what our teacher, Dr. Sheshadri, used to always say that, sometimes the reports just don't make sense. You don't know whether you go by T4 or free T4. What is still important for all of us as physicians is to treat the patient and not the report. We evaluate our patients clinically and rely more on our clinical acumen rather than just blindly looking at reports and treating them. Thank you very much, and I'm happy to take questions.